everyone. Welcome to the Preemie Chats. Preemie Chats is our weekly educational sessions for healthcare providers and parents to talk about what matters to you, to explore new ideas, and to learn together. I'm Fabiana Bacchini. I am a Preemie parent and Executive Director of the Canadian Premature Babies Foundation, as known as CPBF, and I'm happy to be your host today. CPBF is a parent-led organization that helps families in and after their NICU stay through education, support, and advocacy. If you have a heart for preemies, whether you are a family or a healthcare professional, please check our website, canadianpreemies.org. There you'll find resources, the latest projects, and most importantly, a community of people who wants to see our little babies thrive. And if you're watching this session live today, please bring your voice to the table. Leave comments and questions in the chat and we'll try to address them during our program. It is through rich conversations like this that we can advance practice and learn together. So please participate and let us know where you're watching from. And today we're going to talk about the development of skin in utero and in premature and full-term babies. We're going to describe the unique challenges babies face versus adults. We'll also discuss best practices for skincare and strategies to prevent diaper dermatitis, the most common skin challenge faced by our babies. And I have here joining us live from Cincinnati, Ohio, Dr. Andrew Carr, who is a biochemist and pharmacologist with a wealth of experience in designing multinational clinical studies examining baby skin, microbiome, and stool properties. Dr. Carr has been working as a clinical specialist for Procter Gamble, the makers of Pampers, diapers, and wipes, since 2001, and is a member of the Society for Pediatric Dermatology and the Association for Women's Health, Obstetrics and Neonatal Nurses. He's passionate about conducting research in premature and full-term infants to further our understanding of the importance of skin in their growth and development, and has numerous peer-reviewed publications in this area. Dr. Carr, thank you so much for being here with us today.
Yes, thanks for having me. I really appreciate it. I'm very delighted to talk for the Canadian Premature Babies Foundation. I'm very happy to talk about skin and answer questions, and I hope people will enjoy the presentation and learn something about the body's largest organ.
Absolutely. Thank you so much. And please do send your questions, and Dr. Carr will address them at the end of his presentation. Dr. Carr, the floor is yours.
Great. Thanks so much. So very happy to be here. It's always a good idea to start a presentation with pictures of beautiful babies and their skin. We'll finish with that as well. So just some background and disclosures. I think Fabiana said most of this, so I would just say that I really have a lot of passion for skin. I just got back from the Society for Pediatric Dermatology meeting. I'm one of 9 kids. I love babies. I've been around babies my entire life, so very comfortable and happy to be in the pediatric space. I do want to share that while I do have a PhD, I'm not a medical physician. I don't practice. I don't see patients. And the data that I'm going to share today in the presentation are really for informational and educational purposes only, and should not be taken as medical advice. For medical related questions, please consult your physician or healthcare professional, although I'm happy to try to address at least what the science says around a lot of the issues relating to skin. So with that out of the way, we're going to start with fetal skin development. So always good to start at the beginning. So obviously, we start with the fertilized egg, but not too far after that, our body starts to develop into our organ systems. And one of those organ systems is the skin. Another one is the brain. And it might be surprising to some that the fetal skin actually comes from what's called the ectoderm. You don't have to know what that is, but that's the same tissue that the brain comes from. So from the very beginnings of life, our brain and our skin are already connected and communicating. As I mentioned, it's the largest organ of the body, although a lot of times we forget it. About 20% of our body mass. And in adults, it's again, staggering 18,000 square centimeters of skin on our bodies. So again, there's that relationship. This cartoon here is the skin and the brain talking to each other. So, how do we know that the skin and brain are talking to each other? This might be obvious, but I could probably state something like the birth of your child, a wedding, or something like that. And that thought will actually cause your skin to respond, the blood flow, the hair to stand up. At the same time, of course, when we touch things, we experience that touch in the brain. So if we look at brain development in the early parts of gestation, so this graph shows brain development over time at the top, and across the bottom, this is the gestational age. So this is the largely in utero period. And you may or may not be surprised to know that where this star is over here around 8 weeks, this is where our sense of touch is first starting to develop. So it's the first sense to develop. And babies in the 25 to 37 weeks gestational age, their brain are growing at the fastest rate of your entire life. So total brain and cerebral volume are increasing 230%, our brainstem growing at 134%, the cerebellum 384%. And a full 60% of the infant's energy is going into brain development versus 20% in adults. And this really speaks to why there are many benefits to skin that we know are important for baby's growth and development, the connection between mom and baby. And it's this skin to skin that is happening. The chest muscles, they're what are called C afferent nerve fibers in the chest that directly are signaling that brain to release these hormones, if you will, oxytocin and the like, that you may have heard about in other talks that are available on this website, that really, help with the bonding and the experience, the growth and development of these babies. And what you can see over here on the left-hand side is neural development is extremely important. So our body is creating, trillions of neural connections, and hopefully those connections all will be fruitful. And that's how our brains and our bodies are able to speak to each other. And so a question is how diaper dermatitis or dermatitis in general might impact this process. So I love this phrase of touch the skin and the skin touches you back. So as we touch something, we not only send a signal to what we're touching, but also our skin communicates back to us. In terms of fetal skin development, so already at 4 weeks of age, we have what's called a basal or the basale layer of keratinocytes. So keratinocytes are the primary building blocks of the epidermis, that outermost layer. And that's what I'm going to talk about most today. So when you think about the majority of the skin structure, we have the dermis underneath, which you can think of that as almost like the foundation of the house. And above that is the epidermis. And we're going to spend a lot of time, most of our time, focusing on that. And this basale layer is formed, and these are keratinocytes. These keratinocytes, their job for the rest of your life are to divide and make new keratinocytes, and they do that indefinitely. And about 5 to 8 weeks gestational age now, the melanocytes, or the cells that are involved in making melanin, which gives skin its pigmentation, are in place. And about around 8 to 14 weeks gestational age, the keratinocytes now proliferate into a new layer called the spinous layer. And then from 16 to 26 weeks gestational age, the granular layer has now appeared, and maybe potentially some of what's the outermost layer of our skin called the stratum corneum. And that stratum corneum is a very important layer. The granular layer is quite important because what you'll learn about here in the next couple of slides is that the skin is full of proteins and lipids that help form that barrier and provide that barrier function to keep things out of the skin, if you will. And the stratum corneum plays an important role there. The granular cells are the ones that are making a lot of these lipids. And the skin has a property that's very similar to actually blood clotting, which is when we have a cut, our body secretes things like platelets, et cetera, that very quickly block that blood flow. The skin has kind of a similar mechanism, but it uses lipids to do that. So when there's an invasion, it secretes these lipids or dump these lipids and actually help basically get the barrier back into normal shape to protect. This is just a picture of the skin for those who maybe do not have not had a baby that young. This is a 25-week-old baby, and you can see that the skin looks very different than full-term skin. You can see the reddening of the appearance. It's almost translucent. Again, we can actually see in many cases the blood vessels here. So what about now fast forwarding where we have a baby that's born at full term? So full term skin, even though it still has room to develop, it is actually has a well-formed stratum corneum. So the difference between this cartoon and the one that I showed before are, you can see all of these layers of stratum corneum here. So these are basically corneocytes that have thinned out, and they are connected to each other, and they form this kind of wall, if you will, to try to keep things out of the skin. At the same time, you'll see this cell here, Langerhans cell. So I don't want people to forget that our skin, because it is exposed to the external environment, it is a very important part of our immune system, and it is constantly doing surveillance to look at any kind of invasions or repair that is needed. So at full term babies, their skin is actually functional, so it is able to be a very good barrier. And importantly, the skin renews itself. So this kind of conveyor belt of basale to spinous layer to granular layer to stratum corneum, this is kind of renewing itself all of the time. And what happens is these outer layers of the stratum corneum will actually slough off, and those actually become dust in our house. So about 90% of the dust in your house is actually skin cells. Sorry for those that are bothered by that. So what does this look like actually at the tissue level? Those were cartoons. These are actual skin samples that are stained with what's called H&E stain, hematoxylin and eosin staining. And hopefully what you can see very clearly is on the left-hand side is a section from a baby that's 23 weeks gestational age. On the right-hand side, a full-term baby. And I've tried to line them up. The pictures aren't exactly right. But what you can see is the dermis is very unorganized versus a very nice flow. You have what are called ridges here, which are kind of a sign of mature skin. And you can see many layers here in the epithelium. So this is the basal cells, the the spinous layer, the granular cells. And then you have this nice, beautiful area of the stratum corneum. You can see how thick the skin is. When you compare that on the left-hand side to the premature infant skin, there's really not much going on in terms of the epithelial cell layers. You could only see a couple. You can see the basale layer here, and really you can only see a very small portion here of stratum corneum being formed. So this skin obviously is not as robust of a protector as our full-term skin. If we zoom into this, and I don't want to get too much into the biochemistry, but basically the reality is, and the physiology is that that outer layer, it is connected by proteins. So the corneocytes, if you will, kind of are holding hands to form that very tight bond. And in between the corneocytes, it's packed with these lipids, which are hydrophobic. So they repel or keep out substances, including even things like liquids or those types of things. So again, just keep that in mind, because it will become important as we talk later, that the skin, think of it as loaded with proteins and lipids, and these are very important in terms of products that you might hear on market, things that contain ceramides or fatty acids or cholesterols. I know cholesterol has a bad name, but cholesterol is actually very important in the structure of cells and proteins, or excuse me, cells and various structures like the skin. So you might be wondering, how does all of this happen in utero? Because the baby is essentially surrounded in liquid, right, in amniotic fluid. And if you've ever cut yourself and you put a bandage on it, you know that the skin looks like this. So not a very pleasant looking skin. It's discolored, it's wrinkled. And so why doesn't that happen to the baby? And the reason is, depending on the gestational age of the baby, is this right here. So this is a baby that was born near full term, and it is covered essentially head to toe with a substance called vernix or vernix caseosa. And we'll talk about that. So first of all, it's a Latin term. It actually means cheesy varnish. So from the beginning, we knew that it had this protective layer. And in fact, emollients or topical creams that are on the market today are inspired by nature, if you will, from the standpoint of trying to copy the function of this vernix caseosa. So where does the vernix come from? It actually comes from the baby. So the baby starts to secrete this cheesy varnish around 29 weeks gestational age, and that then moves and covers the surface of the skin. It's about 80% water, 10% proteins, 10% lipids. and it contains antimicrobials, which is really important. And then post-birth, usually this has been wiped off, but more and more medical professionals are leaving this on and trying to actually rub it into the skin because it can help increase that skin hydration. Again, the skin is going to go through a shocking process of being in liquid, covered with vernix potentially, and then now it's in an arid environment, a dry environment where it doesn't have that. So the skin goes through this period very early on of drying out. So this vernix can actually help with the skin hydration. It helps protect from damage, just like putting on a topical cream. And importantly, it helps facilitate the lowering of pH, and we're going to talk about that in a minute. And it increases things like natural moisturizing factor to help that skin hold water in this new dry environment. Now, I mentioned that it starts at about 29 weeks, which means for babies that are born before 29 weeks, they're actually born without this protective layer, if you will. And it's also true, I don't want people to be concerned, in full-term babies, they may also have a very thin layer of the vernix caseoso because as that skin is developed, it doesn't need the vernix at that point. So what are some of the differences between newborn and baby skin and adult skin? So those corneocytes, that outer layer, they're about 20% smaller. The keratinocytes themselves are around 10% smaller in the babies. The entire length or thickness of that epithelial cell here, the epidermis here is, it's about 40% thinner. And I didn't talk much about the dermis, but the dermis, that kind of foundational layer of the skin, is actually 3.5 times thinner. And in terms of some of the properties of baby skin, it has a greater water holding capacity, but it also loses water more, and it's able to absorb water because of that natural moisturizing factor. So it holds the water. So you have to be careful, though, that because it's able to lose that water faster, we need to have ways of making sure that the barrier is keeping the skin hydrated. And also greater cell turnover. So babies are able to heal from wounding faster. That conveyor belt, if you will, is happening at a much higher rate. So at this point, I want to talk a little bit about something you might not think about, which is that our skin actually is allowing water to leak from this. So if you did something like put, a cup on your arm for a long period of time, there would actually be beads of water that are forming because our skin is leaking water. And this is really an interesting way for us to measure skin barrier function, because when the skin is damaged, and I'm showing that by these lines here, or the skin is premature, and you can see here that this is a baby that doesn't have a very strong stratum corneum. This could also happen during wounding. You can see that these arrows are meant to mean that the what's called transepidermal water loss, or the water that's going through the epidermis, is actually increasing. So that's a nice tool for us to understand what the barrier function is. This is just to show you that I've talked about this as if skin is one structure and it's the same everywhere. In fact, the thickness of that stratum corneum layer is different. So one of the more thin layers of the body include things like the eyelids or the nasolabial fold that is here. At the same time, if you compare that to the chest, the stratum corneum is almost twice the number of layers. And then I'll just mention for awareness, if you look at things like the hands, the palm of the hands and the soles of the feet, you can see numbers here, 25, 30, 50, 86 on the heel. And that's actually because what I didn't tell you is that there is another layer that is present, the lucidum, that is present on the palms and the feet only. So what are the critical functions of skin? Well, we talked a little bit about barrier protection, that outer layer of stratum corneum, but also sensory. Of course, this is how we touch. It's how we feel. We're going to talk a little bit about the acid mantle. So the outer layer of skin is actually called the acid mantle. And I encourage people to keep using that term, because that way it really emphasizes that the external surface of the skin is acidic. It's important in temperature regulation. When the skin is damaged, for example, burn victims, it actually loses water and heat very quickly. So it does provide this insulating factor. Water and electrolyte regulation, and then immunity. Again, so these cells, like these Langerhans cells that are part of the immune system, they are constantly surveying the condition of the skin and whether there's any invaders. And I mentioned that transepidermal water loss, that leakage. And what you can see here on this graph at the right is the lower the number, it means there's less leaking, which means the barrier is operating very good. So here in, probably about 34 weeks gestational age to full term, you see that the leaking of water is very low. But the more and more premature babies are born, you can see that that leakage rate reaches, 75 grams per meter squared per hour. So again, that can tell us, what that skin condition is. And here is an example. I don't know why this isn't building. Uh-oh. In any case, what this was going to show you is the 23 weeks gestational age, the 24 weeks, and then 26. And what you can see here in the middle is that the transepidermal water loss is high in these babies, and it takes it 7 weeks for the barrier to actually form such that it is equivalent to the full term. And I apologize that these aren't showing up, but on the right-hand side, what you would see is this same curve would only take 2 to 3 weeks. So even though the baby is born 2 weeks farther along in development, it's much faster capable of making up the full term. Whereas if you look on the this graph, what it would have shown you is that, again, it matters. Even though the baby is only born 1 week earlier, it takes it now 9 weeks to form the barrier of a full term infant. So why is all of this important? So I'm going to quote here from the Association of Women's Health, Obstetrics and Neonatal Nurses and the National Academy of Neonatal Nurses, who have developed a skincare guideline, which the 4th edition was published in 2018. And what it says is, early exposure to skin irritants influence the development of atopic or allergy of skin events in later life and can negatively impact neural development. So, wow, that's a shocking statement, right? Which is, we need to make sure that we're thinking about skin health of these babies, premature or full term, from the very beginnings of life, because it could have an impact on skin diseases later in life. And then again, because the skin and the brain are communicating, how do these skin events impact neural development? So again, we want to get a good starting point here. So we don't want to lose the race at the starting line, as they say. And this whole idea of atopic march or allergy, what you can see is this is something that happens very early on in life. And it's part of what's called the allergic triad. So it's not uncommon. About 1 in 5 babies will be diagnosed with atopic dermatitis. And many of those babies will go on to develop food allergies, which is not necessarily considered part of the triad, but asthma, as well as allergic rhinitis. So allergic rhinitis is respiratory allergy, so being allergic to things like mold, dust, pollens, etc. And you can see here, these are some examples of babies of different skin color who have lesions from atopic dermatitis. And so one of the questions I have, which is not answered, is what would be the role of diaper dermatitis, which again is a part of the dermatitis, part of this skin infection, in terms of these events. So let's talk now about pH. I've already mentioned this. This is a little bit of a play on words. So pH, the basic facts here. So pH can give an F sound. What is pH? So pH, the P stands for the power of hydrogen. So hydrogen is an ion, if you'll remember back to chemistry days, and it's the concentration of that hydrogen ion. You don't really have to remember anything about the high school chemistry. I don't want to traumatize anyone, but essentially acidic solutions have a low pH value, and that means they have a higher concentration of hydrogen ions, and things that are basic or alkaline have a higher pH value but lower concentration of hydrogen ions. So many biological processes are regulated or influenced by pH, including skin development. So this is just a graph to show you the scale. The lowest pH value is 0, 1, 2, 3, 4, 5, all the way up to 14. I put in here some of the things that you might be familiar with. So if you think about drain cleaner or bleach, very acidic. Ammonia is here at 11. And our blood, our bodies are around 7.4. Water is around 7. And you might be interested to know that skin is actually down here in the acidic range. So it's more like tomato juice or coffee. So that becomes important as we think about how do we care for the skin. Should we be using products that are actually matching and supporting the pH of the skin, which is going to be more in that 4 to 5 and 6 range here. So looking at this is really important, which is regardless of whether a baby is born premature or full term, they all start with about the same pH. So this is the days since delivery, and this is the pH. So pH 5, 5.5, 6, 6.5, and you can see that it's high. So 7, if you'll remember, is neutral, and you can see that most of the babies are born with the pH of that around 7, and then it very rapidly acidifies down to around 5. Now, what this graph also shows is that the more premature the baby, it does slow this down and it struggles to get that pH down to the same level as a full-term baby. Okay, so this slide is very busy, but again, going back to that concept of acid mantle, why is this important? So the acid mantle is important because it can influence the microbiome, the bugs that are growing on our skin. And I'm not going to talk about any of this in detail, but other than to say that the microbiome is important. The homeostasis of the skin, so its ability to kind of be normal, if you will. That desquamation or the sloughing off of skin is also dependent on pH, as well as the generation of lipids. So for the skin to have the lipids that it needs, it is going to need that pH to be low. It helps the skin have its protective lipids, so to speak. And I'm not going to talk about these pathways at all, other than to say when something is important for the skin or for the body, it builds in redundancy. And there are at least 4 different mechanisms that result in the acidification of the skin. So it tells you that the body is spending time and energy to make sure that the surface of the skin is acidic. At the same time, this is just kind of the opposite, which is high skin pH can actually be a warning sign for us because it is going to impact the microbiome in a negative way, change the homeostasis of the skin, change the speed of that conveyor belt, and also potentially impact the lipid synthesis. So now I'm going to talk a bit about diapered skin. So that was kind of skin across the whole body. We have to recognize that the skin in the diapered area is different. So where undiapered skin, potentially you have clothes on it, it's intermittently covered. The diapered area is, occluded nearly all the time by having a diaper on it. The topography, instead of being flat, as every parent would know, there's these convex, concaves, cracks and crevices. While most of our skin is exposed to UV, some of the key insults in the diapered area are urine and feces. And while humidity is generally, again, indoors 35 to 45, in the diaper, even under dry conditions, it's around 55%. And once the baby urinates, it's going to be over 90%. There's also elevated temperature. And then in terms of just the cleaning, again, the frequency is much higher, cleaning several times a day. So I want to talk about what some people call diaper dermatitis. I don't call it diaper dermatitis. I call it dermatitis in the diapered area because I think the word diaper dermatitis makes it appear that the diapers are somehow causing it instead of it being the location where the dermatitis is occurring. And it is an inflammatory reaction. So inflammation or a dermatitis is characterized by 4 key signs: pain, heat or temperature increase, the appearance of redness, and then swelling or edema. It's the most common ailment in infants, and it's the result of physical, chemical, enzymatic, and microbial factors. It's characterized by a redness, but can also include papules or red bumps, if you will, and then pustules, which are red bumps that actually have pus in them, giving a signal of a more severe infection. The literature is kind of all over the place in terms of the frequency of this, but I think it is fair to say that every baby will experience diaper dermatitis. And the incidence is actually quite high in the first week of life. 70% of babies will have this. In the NICU, again, the numbers are somewhere around 1/4 to 1/3 of babies at any given time will have diaper dermatitis. And babies who have neonatal opioid withdrawal syndrome, over 85% are having that, again, due to the frequent stooling events in those babies. So what is actually happening with diaper dermatitis? So this is our skin, and I'm sorry to say this to people, but we do have bacteria on our skin. Some of those bacteria can be more pathological. Some of them are there, and we live in communion. We call them commensal bacteria. But there's also external forces like viruses, allergens, and fungi. And when there is a breach of the skin, how does that breach happen, especially in the diapered area? Well, as I mentioned, if you'll remember back, I talked about the skin being full of proteins and lipids, and that is what's helping form these barriers. Well, unfortunately, our stool has digestive enzymes, right? The stool comes from our digestive system, and those enzymes that help process and digest our food and chop up the proteins and the lipids in the food that we eat, when that stool is now sitting on the skin, those enzymes don't know whether they're chewing on baby skin or whether they're chewing on something the baby ate. Those anti-lipids or lipases or anti-protein enzymes that digest the proteins, they chew through the layers of skin and they form these invaginations that then allow these bacteria, viruses, and fungi to now invade the skin. That invokes an immune response or a reaction that shows up as dermatitis. So what are the causes of the skin breakdown? So again, dermatitis is an inflammatory response due to compromised skin. It includes things like overhydration, increases in skin pH, stool left on the skin, as well as friction. And these things don't operate individually, they actually are connected. So for example, when the skin is overhydrated, that actually increases the coefficient of friction. It makes things harder to be rubbed against the skin. And so rubbing the same thing across skin when it's wet causes more damage. Some other contributing factors are things like antibiotics or prescription drug use, allergies to food, etc., changes in diet or fortification as babies get more complex in their diet. It changes the stool composition, and it can result in, if you will, more activation of those proteases and lipases that chew up the lipids and the proteins in the skin. Opioids. So again, I mentioned that babies with neonatal opioid withdrawal syndrome have more frequent bowel movements, but also more damage to the skin. Potentially underlying underdeveloped skin, so premature skin, and then diarrhea. Frequency of stool. The more that is rubbing, that area becomes very wet, and then as it's rubbed, and so that's where you would rather blot the skin or rinse it instead of wiping or rubbing it intently. Another thing that is very important about the diapered area skin is that compared to the rest of the body, this non-diapered skin, what you can see in this graph is that the pH that is being measured in the diapered area is actually higher than the rest of the body. So again, that shouldn't be happening. So there's something going on in the diapered area. And the reason that this is important is because, as I was mentioning, those enzymes that chew up the proteins and lipids in the skin, they are used to operating at a more neutral or pH of 7. And what I've shown here is an example of a curve for one of those proteases. And what you can see is this is the amount of activity. So 100% means that enzyme is chewing as fast as it can, and 0 means it's completely shut off. And what you can see is those digestive enzymes that are now in the stool and sitting on skin, they're inactivated down here near skin pH. But when the pH goes up and it becomes more like the pH of something like water, for example, a pH of 7, they become much more aggressive in sitting on the skin. So we want to be doing things that help maintain that skin pH and help keep those enzymes in the low pH environment where they're shut off. So ideally, we would like to not have to worry about treating diaper dermatitis or dermatitis in the diapered area and instead be working on prevention strategies. How do we keep from getting this in the first place? So these are some recommendations. This is from an article by Rika Bloom-Pitavi that was part of a roundtable. And what you can see is they recommend frequent diaper changes using super absorbent diapers to try to pull that urine and stool away, using wipes and or washcloth and water, and ideally wipes that have a pH that helps match that acidic skin pH. And then in addition, using topical products, barrier creams on the skin to help that skin correct any kind of barrier flaws that it might have. I'm not going to go into this to any detail, but it was mentioned that I work for Pampers. We do have resources on our website. This is one of them that you can get. This was written by Lauren Heimel and Carolyn Lund. And it really does focus on the NICU neonates and what can be done in terms of preventing it on non-excoriated skin, and then what to do once the skin has breaking down. It has information on there about cleaning, the application of barrier creams, a crusting technique, which again, this is something more that would be done in the NICU by nurses, not parents. And then, the limiting the use of powders, for example. I'm not going to go into this today, but happy to come back and talk at another time. The other things that are covered in the AWHONN and NAN guidelines include things like assessing the skin every day. We need to be paying attention to skin. I know that sounds obvious because our skin is so visible, but a lot of times we skip and we don't look at the skin to really know what's going on. There's also information in there about bathing frequency, things like water quality, whether it's okay to use, or what are the implications of using a water that is hard or very ionated, the temperature of the water that's safe, products to be used in bathing, etc., and safe practices, what topical products, the importance of thinking about genetics and the family history. So atopic dermatitis has a genetic component to it where, having a parent with atopic dermatitis or both parents with atopic dermatitis do signal an increased risk of this skin condition that, again, is affecting 1 in 5 infants. Vernix retention and what can be done there in terms of leaving that on the skin, and things like circumcision or umbilical cord care that I'm not going to talk about today. So in terms of, what is the evidence? In the field that I work in, a lot of what I hear are that the products are all the same. So, does one product really different? Is it one diaper different from another? Is one wipe different from another? So this is a study that we conducted and that we published in the Journal of Neonatology. And again, we're using evidence-based medicine. So this isn't just, we think the product is doing well. We went and we tested it in the neonatal intensive care unit. And we compared it versus what was at the time the standard for the hospital, which was washcloth and water. And our wipe has an acidic pH that matches the skin pH, and it has a buffering system, which means that it's able to hold that pH down in that acidic range to help offset the urine in the stool that can result in increasing that pH. These are the results of the study, and I'll just kind of go through this quickly. The take-home message is that when the low pH buffered wipe was compared versus washcloth and water, it was actually shown to improve barrier function. It helped lower the skin pH, and it also reduced the dermatitis or the erythema that was seen in those early days that I mentioned before. So this is really impressive to have this kind of evidence in the neonatal intensive care unit showing that it really does matter what products are being used. And this actually resulted in the hospital converting from using washcloth and water to the low pH buffered disposable wipe. So in terms of the NICU, what about these babies that are considered peri-viable? So these would be babies that are, let's say, 24, 25, 26 weeks gestational age, where the skin now very little stratum corneum on it. And so this is a new publication that are called the peri-viable guidelines. And essentially what they did was they said, if the skin is, if you will, normal for these age babies, so that there's no erythema, no dermatitis noticed, what they say is that it should be cleansed gently by blotting with a diaper wipe buffered to skin pH of around 4 to 5.5 to remove the stool and deactivate those enzymes that attack the proteins and the lipids in the skin. And importantly, to also assist in skin barrier repair. So this low pH can actually help the skin heal itself. So what if there is some skin breakdown, there's some dermatitis, it's not very severe, but there's dermatitis present? Well, I'm not going to read this to you again, but basically it's exactly what I told you. So even when the skin is broken down, the recommendation is to use these low pH wipes to deactivate the enzymes and assist in skin barrier repair. And then even if skin is excoriated, so now that you can actually see that the skin is at what we call the glistening layer, the advice is the same, which is to use those low pH wipes. So we're getting close to time here. I just want to kind of close with kind of what is best skin, and it is a balancing act. So it's not a matter of all the way. It's kind of the Goldilocks principle, which is we don't want skin to be dry, but we also don't want it to be too wet. The skin pH should be down in the 4.5, 5.5 range. We want to do things that help support the microbiome, and the microbiome that is there, it wants to grow and live in that acidic environment. And when the pH gets higher, it favors the growth of things like Staphylococcus aureus or even Candida fungi that can then grow and cause skin problems. We want the skin to be clean enough. So we don't want to try to scrub the microbiome off, but we don't want to leave residual stool on the skin. And so we want to use blotting techniques, especially in premature babies. And then we want that barrier to be strong. We want it to be able to renew and correct itself. We want it to be able to breathe. So it's okay that it's, quote, leaking water, but we don't want it to be losing so much water that it can actually cause a hydration issue. And then to be resilient. And ideally, the diapered area should be like wearing no diaper at all. It should look like the rest of the body, the chest, the thigh, etc. So in summary, skin is our body's first line of defense to external irritants, allergens, bacteria, viruses. The skin is constantly renewing itself. That is intentional. So if you don't like your skin, you'll have a new version of it in about 25 days or so. And in maintaining the skin barrier is a priority for the body, and maintaining that low pH is a key priority. The body is trying to do that. We should use products or use techniques that help maintain that acid mantle so that the skin can really perform its best. And that good skincare starts from birth. So I'm going to skip the last bit because we're out of time, and I will finish and take questions. It's always good to finish with babies images of the cutest babies and their skin.
Thank you, Dr. Carr, so much for your presentation. Wow, I learned so much about skin.
Oh,
I had
good.
no idea there was so many components to the development of the skin. It's fascinating to learn and understand a little bit more and how we can support our families a little bit better. So
Great.
we have a question here about, you mentioned early exposure of skin irritants. What are they and how to prevent when the baby's in the NICU?
Yeah, great question. So some of those, so irritants is kind of a general term. It would include things like irritants that can be found in urine or might be generated. It includes those properties of stool. So irritants like I didn't mention this, but like bile salts that are secreted in the biliary tract can be irritating to skin. It includes things like those enzymes that chew up the lipids and the proteins. So the key is making sure that we're using good skincare practices to get rid of those irritants, and doing so in a way that doesn't damage the structure of the skin. So not, with aggressive rubbing. So we want to be gentle and careful. And so those are the things that the nurses, I think, are trying to do a very good job of. It's just difficult because there's the babies are going to be peeing and stooling, frequently throughout the day. Most hospitals I work with, they're on a schedule where every, 6 to 8 hours, 6 to 8 times per day, every 3 or 4 hours, they're going to be changing the diaper and cleaning the skin, etc. But that does leave some time in between where there might be stool or urine sitting on the skin and they're unaware of it. And so that's another piece of using those products that are supportive of the skin and can kind of reject the insults coming from the urine and the stool and protect the skin in between those diaper changes.
Correct. And I have a couple of questions there. One is because we know Pampers diaper specifically, that's the one I know, has the blue line if it's full. Is this the same for the preemie diaper that I use? So in between the changes of the babies, you can see there is a stool or urine there?
Yeah, good question. Some of our diapers do have that technology, what we call a urine indicator, so you can see the color change. And so we've actually expanded that to include 3 stripes because some of the urine actually can go left or right. It's not always in the middle. And so there are actually 3 stripes that can turn blue, and it can give you an idea whether any of those are lighting up. And I believe this is more of a technical question, but I believe it can detect as little as 5 or 10 mLs of fluid. So even small amounts, it will alert the nurse or the mom about the urination event.
Great. And my next question is, more parents are involved into the care of their babies in the ICU, and many parents are doing the diaper change, as we know, and we're really promoting parent engagement in the ICU. What are the tips for the parents who are very involved on when changing the baby's diaper?
Yeah, great question. I think first of all, it's always good to have a good mentor. So, a nurse who is helping guide them to understand. As you get into more premature babies, I want to be careful here because babies that are very premature and very early on, those are going to be babies that probably the parents should not change, and it should be the nurse who's doing that. There is a risk to babies, especially in the first few days of life that are very premature. And I think these are talks that are already on Preemie chats, the risk of IVH problems, et cetera. So for that, the mom should really make sure that the baby is stable and, that they have, I would say, at least starting off to have help and assistance in doing that. Because what we have actually found is, and this is in the literature, diaper changes are actually stressful for the baby, just moving them around and these kinds of things. So you do want to be gentle. The good news is that unlike the nurse, the babies actually know things like their mom's voice and their mom's smell. So that can be something that is calming for the baby. And in some ways, that may help reduce the stress that could happen when we're engaging the baby and performing even things like the nursing care.
Absolutely. And it's such an important moment for the parents because this is one, from my own experience that I see with my 26-week, it was the moment I actually felt like a mom, doing some of the normal things that we expect to do at home when you actually do in the hospital, with a lot of coaching for sure, because there's so many lines, especially on the first few days. You don't know what to do, how much you can lift the leg, and what do
Yes.
you do with all those leads and the wires inside the incubator. So it is great. Absolutely, always ask the nurse and get the nurse guiding the new parents on how to do that safely.
Yes.
So we have a question here from our live audience. I'm going to bring it up here.
Okay.
That's from Sarah. Sarah, thanks so much for joining us here. Do natural oil barrier products such as French liniment, which contains olive oil instead of Vaseline, for example, help with the pH balance?
Yeah, great question. I think so. First of all, natural oils are kind of all over the place. So there's coconut, there's sunflower, there's mustard. I mean, there's so many different ones. I think it's kind of a mixture of two things. I don't want to speak to any general product because a lot of these products are processed. So it could be, it's not like they just, squeeze raw olive oil out of the olive and use that directly. So I can't speak to any given brand. I think the point is to provide that moisturization and that barrier. I don't know the pH of quite a bit of those solutions. I would have to do that, but that's something that actually consumers can test themselves to understand the pH. I think the key is the barrier properties. And I will give kind of my personal opinion, which is I do think even with putting on topical products, it is a balance. If you put so much on the skin that it's actually kind of blocking the skin's breathability, what we call occlusive, we don't necessarily want to put on so much that we're in that realm. We don't want to put on so little that it doesn't have that protective property. So I think it really depends on the product. And I'm sorry, that's kind of a vague answer, but the products are so different that are out there. I think each one would have to kind of stand on its own. And that's why for us, we went out and have done clinical studies on our products to make sure that, we can test in an evidence-based way that the product is performing well.
Absolutely. Okay, one last question. We have so many questions here, but our time is limited. I do want you to come back because you had a list of things that are important for families on your presentation.
Sure.
But one question, when to treat the diaper rash or when to call the doctor?
Yeah, great question. So I think in general, diaper rash is usually short term. You can start seeing, benefits of products that are available. I'm trying not to mention brand names, but petrolatum-based products, if you will, that you can find over the counter or at the pharmacy. Usually you should be seeing progress within 2 to 3 days. Now, there are situations where the diaper, what starts as, kind of irritant diaper dermatitis from, let's say, urine and stool, can become more aggressive. So, for example, could turn into a fungal infection or even a bacterial infection. And that is something that is probably not going to be is not going to get better with just some of those kind of traditional topical products. And if you're not seeing improvement in, I would say, 2 or 3 days, that should be something where, and you've maybe even tried a couple of different creams, maybe the clear cream or the white creams. The white creams have zinc oxide in them, which can help with the fungal infection. But if it's not getting better, to maybe then give a call to the healthcare professional and get their advice. Great question. That's probably the biggest question I get.
Well, when you always tell parents, when in doubt, call your doctor or your healthcare provider, because we don't want parents to get misinformation on the internet. Some sites are not reliable, as we know. So just to get the right information at the right time that they need. So talking about resources, I wanted to talk about what resources are available for the healthcare providers. And I know there is a link also for parents. What can they expect from this website, the pampersprofession.com?
Yeah, so this is a website that has a lot of information on it about some of the things that we've talked about and some of the things I didn't put in there. On Pampers Professional, there's a link to, it says healthcare professionals at the top. If you click on that, there are resources for parents as well. So either pampers.com or pampersprofessional.com, you'll find things in there about bathing, about umbilical care, et cetera, that we have partnered with either, pediatric dermatologists, neonatal therapists, et cetera, to write those articles so that we have the best up-to-date medical advice in those areas. So we're happy to provide those things for free through the website to educate and give moms and babies the best start.
Wonderful. Dr. Carr, thank you so much for being here with us today. I really wanted to come back because you had so many other points that we can explore and really educate our families, especially when they go home, because this is another period of the parent's life and how to care for the skin. We can talk about bathing, sunbathing, and so many other things when they're home. So thank you so much for today. I really appreciate you being here with us.
Well, thanks to everybody who helped make this happen and for your time. And thanks for everyone who joined or will join in the future.
Thank you. And to all of you watching us live today, thank you so much for being here on this Preemie chat. And a special thanks to our sponsor, AstraZeneca, who makes education sessions like this one possible. And just a reminder, if you missed part of today's session, head over to canadianpreemies.org. Let me share the website here and to see this episode and all past sessions of the Preemie Chats. You also find many resource and support options available there. And you'll also be reminded that CPBF is a charitable organization and depends on support to continue its important work. Consider how you can support CPBF in its mission to empower families of premature babies every step of the way. Together, we can create a brighter future for all preemies and their families. And we will see you again next Friday, 1 p.m. Eastern Time. Thank you. Stay well.